Transurethral ablation of prostatic utricle cyst using holmium laser. Prostatic cysts may be incidentally visualized during screening for lower urinary tract symptoms, pelvic pain, hematospermia, and infertility. They can be classified based on the presence or absence of sperm. Cysts that contain sperm include Wolffian duct cysts and ejaculatory duct cysts, which are usually lateralized. Those that do not contain sperm include utricle cysts and Mullerian duct cysts, as well as retention cysts or prostatic abscesses. Prostatic utricle itself is a functional, small, blind-ending duct in the midline of the verumontanum between the ejaculatory duct openings. It is thought to be a regressed Mullerian structure that is homologous to the uterus and proximal vagina. During ejaculation, the prostatic utricle contracts, which opens the ejaculatory duct orifices on either side. With regards to pathology, it is important to distinguish between a utricle cyst and utricle enlargement. A utricle cyst may obstruct the flow of seminal fluid, but classically does not contain sperm, while enlargement of the utricle is due to incomplete androgenization and is associated with congenital anomalies such as hypospadias, cryptorchidism, disorders of sexual differentiation. The utricle enlargement also can trap urine and cause post-void dribbling. We present a case of a 33-year-old man with a history of chronic pelvic pain and pain with ejaculation. He is currently married to a 28-year-old woman, and they have been trying to achieve a pregnancy for the past 6 months without success. His initial semen analysis showed low volume ejaculate with a normal pH, decreased sperm concentration of 10 million sperm per milliliter, poor motility, and poor viability. He came to us preoperatively with a CT scan demonstrating a midline cyst of approximately 2 to 3 centimeters in diameter. Also of note, he had dilated seminal vesicles bilaterally. In the office, we performed a transrectal ultrasound to confirm the size and location of the cyst, as well as the size of the seminal vesicles, which measured greater than 1.5 centimeters on both sides. The cyst's distance from the urethra was also estimated to be less than 1 centimeter. Holmium laser was first introduced in the early 1990s for prostatic enucleation for benign prostatic hyperplasia. Holmium laser offers advantages with regard to hemostasis and has been approved as a safe and effective means of treating prostate adenoma that may be too large to treat with traditional transurethral electrical resection. Alternative options to holmium laser for transurethral incision or unroofing of a prostatic utricle cyst include Collins knife incision, bipolar or monopolar loop cautery. Due to the rarity of this condition, there have been no comparative studies to assess for superiority of one method over another. As the depth of penetration of holmium laser is 0.4 millimeters, which is much less than electrocautery, this may allow for more precise incision and ablation of the cyst wall. Another possible advantage is to limit the spread of electrical energy to surrounding structures, leading to less collateral damage and the possibility of secondary obstruction due to scarring. Our objective with this video is to demonstrate a safe and effective approach to the treatment of obstructing midline prostatic utricle cyst using holmium laser. The following list of equipment is recommended, including a long spinal needle, methylene blue dye to inject into the cyst, contrast, a TUR set, O'Connor rectal shield drape, ultrasound with a transrectal probe, and fluoroscopy. The patient was counseled on proceeding to the operating room for transurethral ablation of the prostatic cyst. We began with cystoscopy identifying the verumontanum, which appeared normal on gross inspection. Using holmium laser, with the settings listed to the right of the screen, we began to unroof the area of the cyst, being sure to avoid the position of the ejaculatory ducts on either side. Once we had unroofed the cysts partially, we were able to enter the cyst using the resectoscope. On entering the cysts, we encountered a significant amount of debris and sediment, and found the cyst to have a smooth wall. At the 5 and 7 o'clock positions on the floor of the cyst, we encountered 2 effaced orifices. These were gently intubated using a Pollock catheter, and contrast was injected. On fluoroscopy, we confirmed these to be the openings of the ejaculatory ducts and seminal vesicles. Our retrograde vesiculography confirmed that the ejaculatory ducts themselves were patent. Care was taken to avoid high-volume contrast injection, as this could lead to postoperative orchitis. We then further unroofed the cyst so that the cyst wall itself would not close again. On postoperative follow-up, the patient's symptoms had completely improved, and his semen analysis confirmed a normal volume ejaculate with much improved sperm concentration and motility. In conclusion, we demonstrate safe and effective transurethral ablation of midline prostatic utricle cyst with holmium laser. Transrectal ultrasound or cross-sectional pelvic imaging may be useful for operative planning, identification of the cyst's embryonic origin, its size, and distance from the urethra. Care should be taken to identify the ejaculatory duct openings and also to avoid high-volume retrograde contrast injection. Vesiculography allows one to confirm the patency of the ejaculatory ducts.